Well, good morning, and thank you, Judy, and all your colleagues at the Center again for developing a wonderful summit, cutting-edge issues with great thinkers and advocates from the field. It's a pleasure to introduce today's panel addressing trends in living with advanced illness, which is co-sponsored by Compassion and Choices, as you can see up on the board. And I should add that our entire panel is from Ohio, which is just coincidental. Without question, the past several years have shown considerable policy and political progress in addressing the needs of those facing serious illness. Stakeholders have engaged in policy development, public awareness, campaigns, and clinical innovation. As a result, Congress and the past administration have begun to take on this issue. Yet we have a long way to go to ensuring that individuals' goals, values, preferences in their medical care are always honored by the healthcare providers and the healthcare system overall. Our panel this morning will cover a range of perspectives on trends in advanced illness and end-of-life care. Starting with Amy Berman, who has changed the way many of us think about serious illness and how to direct our care and make our healthcare decisions better reflect our personal values and the type and quality of life we want. When I say she has changed our thinking, actually enlightened us, I mean that she has, with her personal story and her advocacy, changed the way key stakeholders, not just a few of us, the big guys, the big girls, the national academies, organizations such as the Center for Advanced Palliative Care, CTAC, Congress, foundations, and the public think about person-centered advanced illness. I truly am honored to call Amy a friend and a colleague, and Amy, please start us off today.
Good morning, everyone. Are you able to pull up my slides? I can do that. All right. There we go. So welcome, everyone. My name is Amy Berman, and I'm delighted to be here in front of you today. I'm a person who lives with terminal illness. That may shock some of you. You may not expect to hear somebody say terminal illness. It's not a PC term. People say advanced illness. They skirt around what is serious illness. But I live with life-limiting illness, and I'm a real person, and I'm going to tell you a very real story. About 6.5 years ago, I was diagnosed with something called inflammatory breast cancer. Inflammatory breast
need to have with their healthcare providers in order to end up at that place where you're getting the care you really want, having the preferences you want, are much more likely to take place if you're in the Independence at Home program, because people feel comfortable after a bit of after a number of visits from healthcare professionals into their home, having the conversation. You can imagine the difference between that and going into an emergency room or some other healthcare facility and trying to get to that point where you can open up and think that through. So thank you for mentioning that great program. Our second panelist is Kim Callahan, who serves as the Chief Program Officer at Compassion and Choices here in the Washington, D.C. office. CNC has for decades been fighting for patient-centered care and choice at the end of life. You may know them most for their campaigns at the state level to secure access to physician aid in dying, but they also have an excellent counseling program, a robust federal agenda, and have been very active in recent years in the Leadership Council of Aging organizations here in Washington, supporting a wide range of issues, including and especially Medicare. Kim?
Thank you so much, Brian. A little bit about Compassion and Choices. I think what we are really about is, as Brian said, improving care and expanding choice at the end of life. And we have 450,000 supporters across the country. And what I'm here today to talk about is one of the issues that we work on at the state level, which is medical aid in dying. And I want to be really clear that I am not at all suggesting that medical aid in dying becomes a part of Medicare. But we have had such tremendous progress at the state level around this issue that I thought it would be valuable and beneficial for people to understand why this issue is gaining so much traction and momentum, and what that might tell us about how to fashion changes to Medicare that could improve serious illness care at the end of life, the broader issues, and how you might be able to tap into some of that sentiment to make changes. So we heard some really impressive policy minds this morning, and many more sitting at this table, and I'm hoping that something that I say and understanding what people are looking for will inspire creative thinking that we may not have even seen yet. And again, not advocating that this becomes a part of Medicare. First I'm going to talk a little bit about what medical aid in dying is, just to define it for people in the room, and I'm going to ask you, whatever your personal opinion is about it, don't listen to me through your personal perspective. Listen to me to understand why so many people are supporting the issue. I'll talk a little bit about the momentum, but then I mostly want to focus on what this means for end-of-life care. So what medical aid in dying simply is it's an opportunity for somebody who is terminally ill, has a prognosis of 6 months or less to live, to take a prescription medication to end their life peacefully should they choose. And the legislation is very carefully crafted so that it puts the decision in the person's hand. They have to be 18 years or older, terminally ill, prognosis of 6 months or less, and capable of making a decision. And then depending on the state, there are a series of safeguards that are in place in order to ensure that it is the person who's making the decision. 2 doctors certify that it's the person. They have to make sure they're fully informed about all other medical options that are available, and the person has to be able to self-administer the medication. So it's now been in practice in Oregon for combined 30 years, and it's now in 7 jurisdictions, and most recently was just passed within DC and signed into law. What's really fascinating is when you think about the conversations around end of life and how taboo they are, and this is a topic that people don't want to talk about. Yet this is an issue where we've seen legislation pass within the last 2 years in California, a ballot initiative in Colorado that had 2/3 of the vote, and then legislation passed in Washington, D.C. This is at a time where very few issues are making this kind of traction. It started when a young woman, Brittany Menard, came forward and shared her story. I shouldn't really say it started then, it started 30 years ago, but that's really what led to the most recent insurgency of the issue. She came forward and shared her story about moving from California to Oregon in order to access the law. And my organization partnered with her and her husband, Dan, and this is spurred. There's legislation this session in 24 states across the country. So it's really spurred over the last 2 years of a growing national movement. We now have 18% of the population covered by this legislation: Oregon, Washington, Montana, Vermont, California, Colorado, and DC. And no matter what survey you look at or how the question is worded, even if you use the opposition's term assisted suicide, you still have 2/3 of the American public supporting the issue. It has support across bipartisan lines, and we saw in Colorado that people will actually come out, vote favorably for the issue. It received more votes in Colorado than any other issue on the ballot. More people actually came out and voted for the issue, so it was the highest vote total and the highest supported issue on the ballot in Colorado. Democrats, Republicans, Hispanics, African Americans, it didn't matter, it was majority support. So you can also see the question here on a recent Lifeway survey asked the question in another way and also received strong support among various different communities. And we're also seeing a shift taking place within the medical community. There's an article that came out in the Annals of Internal Medicine that was calling for the medical providers and the palliative care community to take a position of engaged neutrality on the issue. basically saying this is something that people want. This represents autonomy and control for people at the end of life, and the medical providers owe it to people in order to respect their values and priorities and to figure out how do we implement this law in a safe and effective way. So I would encourage people to read this article in our packets. We have a copy of that, and there's also a blog article that the CEO of Compassion and Choices, Barbara Coombs-Lee, and I authored that talks more about this. So why the momentum? What can we learn from this and apply to the much broader set of policy issues that are out there? So while my organization passionately believes that this is something that we should see in every state, we will also say this alone does not solve the problems that we are facing with end-of-life care. It is the start. It is not the end-all be-all. We have a huge problem that's out there with people getting treatment that's not consistent with their values and priorities, which Amy did a really nice job talking about her personal experience, and fortunately she was a strong advocate for herself and found the balance and what she wanted, but unfortunately very few people have the skills that she demonstrated to be able to find the kind of care that they were looking for. So that's the big challenge that we have right now within our system. So what can we learn about why people are rallying around aid in dying that helps us to solve that broader problem? So the first thing that medical aid in dying represents for those people that are supportive of it is it's about peace of mind. It is about them knowing, so it's not about how they want to die, it's about how they want to live. It's exactly what Amy was articulating up there for what she was looking for in her care. But for the people that are supportive of this issue, they're saying, I want the peace of mind that knowing that should things become so awful for me, that I have a solution. And just knowing that it's available for many, many people, they don't even choose to go through the process. But they'll say to you, if you do a survey of them, and there's lots of data, and in my blog article we outline the data, they'll say to you, knowing that this is available within my state brings me peace of mind, because it tells me that if it becomes too much, I have an option, I have a way out. So that's the first thing. So as you're thinking about how do we solve the broader issues, how do we talk about the issues in a way that brings people peace of mind? But how do we also fashion issues that are about peace of mind? The second thing is that it brings families together. What happens through this process is that people have conversations with the people around them of what their goals for care are. When they go to their doctor and they talk to the doctor about it, it's required in the legislation that the doctor share all other available options, and the doctor also encourages them to talk to family members. So for the people who choose to go through this process, it really is a family, it becomes a warming of the family, a bringing together of people. It's a beautiful, beautiful experience for people. So that's another important thing. And people want control and autonomy. And this is probably the single biggest thing that aid in dying represents for people. And there's many, many policies that could be translated to the broader end of life issue that are about autonomy and control, and those are the ones that we should be looking for. Because the other reality is we are spending an incredible amount of money torturing people with illnesses that are inconsistent with their values and priorities and cost a fortune. So this is one of the few policy issues where if we actually created a system that allowed people to be fully informed about all available treatment options so they could make the decision for themselves, the decisions that they would choose would cost less money. There's very few policy issues out there where you can actually lead with someone's values and priorities, and all of the data and evidence shows us the outcome is less money. So we know that talking about the financial aspect of this is not necessarily the way to sell, or is not the way to sell the issue. But from a policy perspective, for the really smart people in this room, if we can figure out how do we lead with values and priorities, we're going to see a healthcare system that spends less money. So I talked a little bit about some of the other policy solutions, and we've done some good work around this, around what some of the other policy solutions are. So the first thing that I would say is that we need to look at how to reduce unwanted medical treatment. People right now are getting care that's inconsistent with their values and priorities, and the way we do that is through fully informed information. So right now when you go to the doctor, what Amy articulated is what typically happens to someone. They go to the doctor, the person is given the diagnosis, and they don't know to ask the kinds of smart questions that Amy knew to ask. And so they end up getting tortured with care that had they realized what the consequences would be, they would have never chosen it. So how do we craft policy solutions that ensure that when someone goes to the health system, they're going to be given all available treatment options, not just the one that is the most aggressive care? That's the kind of policy solution that will solve the problem that's out here. There are some states that are doing some really innovative things. Massachusetts is doing something that's really interesting that I think we should pay attention to around patient input on surveys so that patients can talk about whether or not their doctors are giving them care that's consistent with their values and priorities. So that's another thing to watch. I don't know if we've studied it enough to know whether or not it's effective, but it's an interesting solution that that is along the lines of ensuring that people are getting fully informed information and that they're having more control and more autonomy and more input. The last thing that I would say, and this is less about policy solutions, but I just wanted to, for anyone who has constituencies or groups, this might be helpful for them to know. One of the initiatives that Compassion and Choices recently launched is an initiative called Truth in Treatment. And this is designed to get at the problems that we're talking about, but from a consumer movement perspective. So we've created some tools, and we actually have a new one that's going to launch in the next couple of weeks called the Diagnosis Decoder that helps give people the kinds of questions that they need to ask in order to get information that's consistent with their values and priorities. So if that's something, if you have constituencies or people that are looking to get care, I'd encourage you to go to truthandtreatment.org and you can sign up for it. And when the new tool comes up, that's something that you would be able to share with your constituents. Thank you.
Thank you, Kim. And I did go to the website a while back when you first set it up, and there is a very interesting process. One can go through answering questions, and it creates a postcard or a letter that you can send to your physician describing what you would like that relation to be like and the kinds of information you'd want from him or her. So, I recommend you taking a look at that. Our third presenter is Leslie Frane, who is the Executive Vice President of the Service Employees International Union, SEIU. Leslie knows our issue from the healthcare worker perspective and will address, among other issues, the challenges created by the shortage of direct care workers and caregivers, and the importance of training, compensating, and empowering the advanced care workforce. Leslie also knows a lot about organizing at the state, local, and national level, and we all know from last week how important organizing is, and thank you for all you did along those lines as well. Leslie?
Thank you to SEIU for helping to sponsor today.
Thank you. So I join you today on behalf of 2 million members of the Service Employees International Union, half of whom work in the healthcare field. And approximately 700,000 of our members work in long-term care, either as home care workers or as nursing home workers in the United States or Canada. For decades, the members of our union have advocated aggressively for the reform, improvement, and protection of our healthcare system. And they do so really for 3 reasons. First, because they're healthcare providers, and they're passionate about the care that they give to their consumers, their residents, and their patients. Many of our members have told me that they could have made significantly more money going into another field, and they chose healthcare because of their commitment and their dedication to do the very best that they can for the people that they care for. The second reason is because they're employees. And as employees, their careers, their professions, and in fact their livelihoods depend on us having a robust healthcare system that is adequately funded and a stable system. But third, they advocate because they're also consumers. And because so many of our members are low-wage workers, the majority of our workers, particularly in the long-term care sector, either depend on the Affordable Care Act or Medicaid for their own care or for the care of someone in their immediate family. So take the example of Roxana Giron, who is a home care worker in Las Vegas. Roxana cares for 4 clients, 3 of whom are veterans, and she worries about what a tax on healthcare will mean for her ability to meet the needs of the consumers whom she is dedicated to and cares for 7 days a week. She's also the mother of 2 daughters with diabetes, both of whom are on Medicaid, and she knows that a tax on Medicaid may mean that she won't be able to afford insulin for her children. She also gets by working 7 days a week on $10 an hour. And she knows that the attacks on our healthcare system and Medicaid in particular threaten her already fragile ability to make ends meet every day and pay the bills that her family rely on. There are hundreds of thousands of Roxanas all across the country. And at this particular moment, Roxana and so many men and women, particularly women like her, are very nervous about the future of our healthcare system. And I had intended today to talk directly about the attacks on healthcare. I didn't actually realize that I was speaking right after a panel on the Affordable Care Act and Medicaid and Medicare. And I was sort of having, in planning these remarks, a little bit of a so how was the play Mrs. Lincoln moment? Because the comments that I often speak about that have to do with workforce development, that have to do with fair wages for workers, that have to do with the value of unionization and its contribution to increasing healthcare quality, frankly, felt less urgent than the critical moment that we're in. I'm going to change my comments a little bit because I want to be respectful of the fact that you just heard a panel on the Affordable Care Act, Medicaid, and Medicare, and try not to be too redundant. But there are 2 points about that conflict that I would like to make. The first one I think I'll risk being redundant on, and the second one may go off in a different track. The first is that throughout the very intense fight that our members and so many others have waged, defending the Affordable Care Act, defending Medicare, I believe that Medicaid has not been gotten as much central focus as it needs. And this is partly on behalf of our members who are largely paid by Medicaid and whose families depend on Medicaid for care. But it is also because of the way in which Medicaid as an issue has been racialized over the years and dismissed as the poor people's program. Frankly, the advocacy community for Medicaid has been less powerful than the advocacy community for other parts of our healthcare systems. And I think one of the exciting things about what's happened in the last few weeks and the months since the election is I think that's beginning to shift. And the polling shows that Medicaid is more popular than ever. And in fact, the polling that we sponsored and shared with many of our allies and many electeds over the last few months showed that the impact of the repeal bill on seniors and peoples with disability, and particularly Medicaid, was in fact the most unpopular part of that law. So I think we are at a pivot moment in terms of how people view Medicaid. One of the things that I worry about is that while I care enormously about the potential impact of repeal on the Medicaid expansion population, I think there is not enough conversation about the impact of block grants and per capitation on the fundamental promise of the Medicaid system, which has been a guarantee for 51 years and currently provides services to 70 million people, including 13 million seniors and people with disability. So I want to take just a minute on that slightly wonky question. And one of the things that makes this hard is it's hard to talk about in a way that doesn't sound wonky, but about what capitation and block grants mean. And the first thing that they mean is just about the numbers. The bill that was pulled last week would have cut $880 billion out of the Medicaid system over the past 10 years. And at the end of the day, the motivation for that, as the earlier panelists spoke eloquently to, was to save money in order to fund tax cuts for the wealthy. But there is no way that you can cut those kinds of dollars out of the Medicaid system without ending up with less care for fewer people, a lot less care for a lot fewer people. And that is baked into the idea of converting Medicaid to a per capita system or a block grant system. But the second piece that I worry about is actually goes beyond the numbers. It has to do with the future. Because once you make that change, you don't get to move back. Once you switch to capitation or once you switch to block grants, then Medicaid becomes a go-to piggy bank every time there's a budget cut in the future, every time there's a need for a little bit more money. Well, up until now, because it's an entitlement, we've had some level, not complete, but some level of protection. But once that switches to a block-granted program, that protection goes away. Third, the risk transfer, that if you switch to a per capita system or a block grant system, then going forward in the future, then the risk is transferred from the federal government to the states and ultimately to the consumers. And that's a risk if there is inflation in excess of what's anticipated, a risk if there's a public health crisis, or a risk if there's simply demographic shift that leads to an increased acuity level among the Medicaid population. And that risk shift, which ultimately transfers to the states but ends up on the shoulders of consumers, is an inevitable part of that structural change. And so I would say, I stress those points because I don't think they're getting enough play in the media and because they are a little bit wonky, and I feel comfortable in my wonkiness with this audience that you will not hold that against me, but that I think that we need to find a way to stress that point as we go forward in this debate. The second point that I would make specifically about the attacks on healthcare that we're undergoing now is I just wanted to talk a little bit about the struggle in the streets, as I call it. The way that we win this fight, and I believe we can win it, is through a combination of what I like to call the inside game and the outside game. And the inside game is the work that we do here in the Capitol, the lobbying work, the research work, the policy research, the storytelling, all of which is incredibly important. But I believe that at the end of the day, it will also take an incredible amount of just pressure on electeds to get to the right place. I wish that were not the case. I believe that that is the case. And I think that we win this thing in partnership. And so I just wanted to take a minute to talk a little bit about the campaign in the streets, if you will, that has been going on really for years in defense of the healthcare system and the Affordable Care Act, but in a more intense way than ever over the last couple of months. And this is work that SEIU is involved in, but I want to be clear that we do this in partnership with many, many other grassroots organizations, and that the coalition that has built and been strengthened over the last months is something that I believe will endure and be a key way that we can not just defend our healthcare system, but improve it. And so some of the work that we've been engaged in over the last few months and will continue is, first of all, a phone call barrage to electeds. But I want to be clear that we do that in a very targeted way. We don't just have our members call their electeds. In California, just as an example, we had 700 phone lines running where our members, nursing home workers, home care workers, hospital workers, came in after working an 8 or a 10 or a 12-hour shift and sat down on the phones, and they called voters in Nevada. They called voters in Alaska. They called voters in Arizona and said, let me tell you what's at stake in your healthcare system, and then can I connect you to your electeds? And we do that as a way of having an influence beyond what we call our strength states, which tend to be blue states. We also did town halls. If electeds come, we do them in their presence. If not, we do empty chair town halls to get the story told and to do it in a way with as much media focus as we can. And in all of those, Judy mentioned before the importance of story collecting, and all of those we lead with stories to put a personal impact on what the attacks on healthcare mean. We worked hard to engage our employers. And I would say some employers have been just champions throughout this struggle, and some have been a little bit hesitant, a little bit worried about will there be a price to pay if they come out and are critical of policy. And so the work that we've done engaging employers, I think, has been important, as has the work that we've done engaging electeds at the state level who are key stakeholders in this process. But we have also done protests and demonstrations. I was one of 47 people who actually got arrested at the end of January at the Capitol to protest what then looked like it was going to be a rush through repeal of the Affordable Care Act. And I want to tell the story of one of the members that I was arrested with, a home care worker from Missouri who was a 74-year-old home care worker who still worked full-time because she has no retirement plan. And she said, if you had told me that I've worked so hard to keep my kids and my grandkids and now my great-grandkids on the straight and narrow, not getting arrested. If you had told me that I would voluntarily take a arrest, I would have thought you were crazy, but that's not as crazy as what's going on with our healthcare system. So I say that just as a summary of some of the things that we're engaged with, because I was asked to speak on the threats to our ability to deliver quality care for people in advanced stages of illness, and also the ways to support the caregivers who provide that care. And I would argue that at this moment in time, the most important thing that we can do together is to protect the healthcare system that we have built, and then to proceed to improve it. Because my members would give me a very hard time if I didn't acknowledge that the system that we are defending is not perfect for caregivers. We live with average wages of $10 an hour for home care workers, just slightly more for nursing home workers. We live with a world in which until recently those workers weren't even covered by overtime protections or by the minimum wage laws. We live in a world where home care workers and nursing home workers don't get the training that they need and that we know helps them help keep people healthy. And we also live in a world where there are rampant attacks on direct care workers' ability to have a voice on the job through unionization, which is the one thing that we know enables workers to lift wages. And whether it's the home care workers in Massachusetts and New York and California and Washington who recently won $15 an hour when through their union they engaged in the home care fight for 15 to lift up wages, the home care workers in Minnesota who recently won their first paid time off benefit ever, or the home care workers in Washington who won a robust training program that enables them to be the professionals that they want to be and improve the quality of care that they provide every day. So we have a huge crisis on our hands. We have healthcare workers all over the country who want to partner with you in taking on that fight so that we can protect what we've built and then move on to what we need to do to improve the system, both so that we can create the quality jobs which are then attractive enough to recruit the numbers that we need, and create a workforce that is skilled, qualified, trained, and able to deliver the quality of care, the dignity for people, for seniors and people with disabilities, and the choices that people need in their senior years, so that we can have the kind of healthcare justice, which I know is the vision that brought all of us together today.
Wow, that is fantastic. That is fantastic energy, and Judy, we need to have a training session after. But Leslie also reminds us that if we're spending all our time fighting these battles to preserve programs we have, there's much less time for fighting for improvements to programs and innovations, and that's really a multiple downside to what we've just gone through. Finally, that leaves our next speaker with about 45 seconds. No, I'm just kidding. We're in good shape, Charlie. Our fourth speaker, someone many of you know well, the esteemed Charlie Sabatino, is the director of the ABA Commission on Law and Aging. You may recall that we had a special page in last year's program to remind Charlie that we missed him and needed him to get back to work after his horrific bike accident. That was just a year ago. He was still recovering. Well, he's here today, one of the nation's leading experts on advanced care planning, advanced directives, POLST, patient-centered communications, and I must say, one of my favorite people in the world, Charlie Sabatino.
Thank you, Brian. Given that I'm the only thing between you and your delayed break, I'll dispense with my jokes about my connections to Ohio and focus on, I'm going to return to some of the issues that Amy and Kim brought up, but focus more directly on advanced care planning. Starting with, there's some good news and bad news in this area, looking back over the last several years. I'd like to start with this piece that Joan Tino and her colleagues wrote in JAMA in 2013 that looked at the change in end-of-life care for Medicare beneficiaries. And there's good news and bad news in here. You can see from this chart that deaths in acute care hospitals went down by 8% over that period, those 9 years. And the use of hospice went up by an amazing, more than 20%. However, The ICU use during the last month of life also went up by almost 5%. So yes, we're starting to experience end of life in the final location where most people want it, but we're still subject to the pinball phenomena before we get there. And that's not what we want to see, and that also doesn't help save any costs. The Institute of Medicine report, now called the National Academy of Medicine in 2015, was really a hugely important report looking at the evidence from the last 20 years, really. And it affirmed exactly what you've heard from Amy. We do know that most people at the end of life need help in making decisions. Most people, given adequate information, would rather choose caring over curing. And this depends upon frequent clinician, patient, family conversations, and they largely don't happen. And the result is that the default option is aggressive care. Now, we've largely tried to deal with this historically through legislation, which has occurred primarily at the state level, and it's a pretty crowded legislative scene, actually. The focus has been very heavily on advanced directives, which include healthcare powers of attorney and living wills, but also important are guardianship laws. We have about 1.3 million people under guardianship, and many of those need healthcare decisions made for them. Out-of-hospital DNR laws and now POLST have become very important at the last stage of illness. Default surrogate laws are state laws that dictate who can have authority, usually next of kin, to make decisions for you when you haven't appointed anybody, which is the majority of people. And you heard from Kim about the emergence of of physician aid in dying laws. With respect to those advanced directives, what really now 40 years of research tells us is that most people still don't complete advanced directives, although it's a little bit more favorable the older we get. The forms out there, the standardized forms, particularly those in statutes, are hard to understand. Most are written at about the 12th grade level, at least. People change their minds. A friend, colleague of mine at Johns Hopkins, Tom Finucane, a geriatrician, is fond of using what he says is a Spanish proverb, I'll take his word for it, that the bull looks different from inside the ring. And that's how he describes the way we change our minds at the end of life, and I think that is a great deal of wisdom in it. Clinicians tell us that the standard forms don't really provide useful guidance to make in making specific decisions because dying is complicated. The people who are appointed, the agent or proxy, if that has happened, often haven't even had these discussions with the principal, and are therefore uninformed. And healthcare providers are usually clueless about the existence of advanced directive, despite the Patient Self-Determination Act, which asks you to check yes or no when you're admitted to the hospital. It doesn't really require you, unless state law requires it, for them to ask you for a copy of it. Even if a directive exists, it doesn't make it into the record, and even if it's in the record, it can be lost in space in the record. So there's a lot of barriers in making advanced directives work well, and there's been a transformation in the way of thinking about it from these documents we call advanced directives to a process called advanced care planning. The former is a transactional process that is really was embedded in state living will and durable power laws, which focus heavily on standardized forms, on mandatory legal formalities for signing and witnessing the form, for certifying incapacity, even for certifying whether you have a terminal condition. They tend to focus on treatment wishes. Do you want this or do you not want that? So the focus is on the document and on the interesting aspect of these laws. The carrot behind them from the 70s on has always been, well, providers get immunity for following your wishes, which is kind of an oddity. When I look back on it now, it has become such the norm, the standard of practice, that you at least need to listen to, a little bit to what patients tell you. that we got to give people immunity for this. You don't need immunity for doing brain surgery. Their protection is the fact that they follow standard accepted medical protocols. So this transactional approach has moved towards a communication approach, which has less a focus on standardized forms. The Institute of Medicine study I mentioned does talk about advanced directives, but in its conclusions, it's really all about the conversation, because that's where it's happened. I tell lawyers when I do work with them that the advanced directives are only as good as the conversation they're based upon. And if they don't have any conversation behind them, they aren't worth the paper they're written on. So this communication approach is, the legal part of it is focused primarily on naming a proxy. That's a matter of agency law, which is kind of embedded in state legislation. So use the form to name a proxy. Everything else is good communication. And lawyers and legislators don't have any monopoly on what's good communication, believe me. And it's developmental in nature, this process. It is different. Well, there's a definition of advanced care planning in the IOM report. I'm going to skip this for the sake of time because you're getting the sense of it. These conversations that are key to advanced care planning do change over time. When my kids were in their healthy 20s, getting them to muse over scenarios of making decisions at the end of life was the last thing I would ever get them to do. But I could get them to realize that, like me last year, they could have a biking accident and be knocked out of commission for a good few months. And at least during that time, they need somebody to be their proxy to make decisions for them the way that they would want. So they could grok that, and so they focused on a bare bones healthcare proxy, which is perfect for somebody at that developmental stage. When you get to your middle ages and you have some significant chronic conditions, then you become focused more on planning for the long range. It's still very important to name the proxy for you, but when you get to the latter stages and end stages of illness, getting more specific that's when that becomes important. And that's where protocols such as PULSE, which try to convert your goals of care into a specific plan of care with teeth, because it's a medical order that addresses the high probability critical care decisions that you'll face, becomes more important. Now, what I'm saying is really not new news. I like to go back to the National Quality Forum's list of preferred practices in their framework for quality palliative care and hospice care. They had 5 preferred practices that directly summarize what I'm talking about. Documenting and designating a surrogate for every patient in all settings, documenting the patient's preferences for goals of care and treatment options, and converting patients' treatment goals into medical orders at the end of life. They also addressed making advanced directives available across care settings and developing community collaborations to promote advanced care planning. Now, there have been interesting signs of change over the years, such as the CMS approval of the payment codes, and we are seeing medical practice and electronic health technology moving slowly. We're also seeing a very slow shift in states finally agreeing to simplify some aspects of their state law, but it has been very excruciatingly slow process. You have on your tables a list of resources that our program puts out, which includes all of the things you see up here. These are all tools for helping you have the conversation. And everybody approaches this topic differently, so look at different tools. Some you'll resonate towards, some you'll say, I don't like this one at all, but they're really worth looking at. Finally, the last point I want to make is about electronic health records. You know, they've been kind of the end-all and be-all in a lot of scenarios that people imagine. And we've had a lot of ups and downs with things like meaningful use standards, and now the new physician kind of point system that they have for encouraging electronic health records. But, you know, health systems have to use EHR software that's been certified by the Office of the National Coordinator for Health Information Technology under the HITECH Act. And so they set basic standards for these electronic health records. And the ONC certification doesn't require electronic health records to have any separate identifiable field for patient advanced care plans or polls. They could do that. I've talked to people there, and they said, yeah, well, it's within their statutory authority. Why they don't do it? Well, my guess is that the industry of vendors that sells electronic health records would much rather have each system pay them lots of extra money to customize the system for them rather than to have it in the basic plan. Nor do they define what advanced care plans should include in the electronic health record. It should include more than one's advanced directive. It should include any documented advanced care planning discussion with healthcare providers. That is equally, if not more important. And I'm going to stop there and turn it back to Brian.
Thank you. I'm a little surprised Charlie didn't mention that when he has dinner parties, he likes to pull out this board game called How I Would Like to Die. It's really uplifting evening. But anyway, oh, thanks. We don't have time for questions, but I think when you're talking about this issue, you should always end with the patient's perspective. So I'm just going to ask Amy if she has any comments kind of to wrap up this panel.
My closing comment to this esteemed group is that the most important thing is that the care needs to be concordant with a person's wishes. And we need to do everything to be able to support that. If we get it right for the person, we're getting it right for the healthcare system, we're getting it right for the family, we're getting it right for society. Thank you.